Welcome to the Psoriasis on YouTube channel. We cover all things psoriasis on this channel. Despite being less frequent than plaque psoriasis, pustular psoriasis has a substantial impact on those who are affected. There is currently no specific effective long-term therapy for this illness, making it an unmet need in dermatology. Although a person may have both types of psoriasis, pustular psoriasis manifests differently from plaque psoriasis. Plaque psoriasis shows as patches or plaques on the skin's surface with flakes or scales, whereas pustular psoriasis appears as pustules, which are little white or yellow blisters filled with pus. There is no indication of infection in the pus. It is made up of neutrophils, a type of white blood cell. The blisters might be small and broad, or they can be larger and merge together to form pus lakes. The skin around the affected area may also be swollen and irritating. These blisters can arise quickly and all over the body, or they might appear slowly and only affect the palms and soles. The appearance of pustular psoriasis varies depending on the subtype, which is divided into two groups. Palmoplantar pustulosis, PPP, is a localized variant of psoriasis that affects only 5 to 12 people out of every 10,000 people with psoriasis worldwide. It appears on the palms and soles, and it is accompanied by oozing pustules. GPP, or generalized pustular psoriasis, is an even rarer type of the illness that can cause life-threatening problems and necessitates immediate medical intervention. Only 2 to 7 out of every million people with psoriasis are thought to be impacted. People with a history of plaque psoriasis are more likely to develop GPP. Withdrawal from systemic steroid medication is usually linked to this comeback. While some people develop GPP without ever having had psoriatic illness, this is not always the case. They usually have a history of psoriasis, were treated with a systemic steroid, and now the psoriasis has returned with a fury and taken on a pustular form. As a result, doctors tend to avoid providing systemic steroids to psoriasis patients. Smoking, infections or traumas, stress, pregnancy, and the use of tumor necrosis factor and interleukin-17 inhibitors, such as those used to treat other inflammatory illnesses like rheumatoid arthritis, Crohn's disease, and plaque psoriasis, are all possible causes of pustular psoriasis. Pustular psoriasis forms appear pathogenically distinct from plaque-type psoriasis, in addition to their distinct appearance. While the specific origin of pustular psoriasis is unknown, a recent analysis published in Dermatology and Therapy describes the possible involvement of the interleukin-36 pathway. Because pustular psoriasis has such a large impact on individuals, efficient treatment is essential. Nevertheless, it is a difficult illness to manage because many of the therapies used to treat plaque psoriasis are ineffective for pustular psoriasis. Treatments are available for those with advanced illness. Treatment with cyclosporin or acitretin is commonly used, but it has side effects. Unless the person is a woman of childbearing age, acitretin and a topical corticosteroid should be used every day. Cyclosporin is prescribed in this scenario. Acitretin is an oral retinoid that should only be given to male patients or women who are not of childbearing age since it can harm the fetus. Cyclosporin is a calcineurin inhibitor that is used to suppress the immune system. The FDA recommends that cyclosporin not be used for more than 1 year because it has the potential to cause renal failure and hypertension. Similarly, we evaluate clearance at 1 month in females of reproductive age who are on cyclosporin. Generally, we will start weaning the patient if the patient is lucid. The patient will switch to a biologic if the pustular psoriasis flares up during that time. The issue is that biologics' efficacy for pustular psoriasis has been inconclusive. When it comes to plaque-type psoriasis, biologics are effective. However, it can be hit or miss with pustular psoriasis. There is no one biologic that works better for pustular psoriasis than another. Patients with any type of psoriasis should consult their primary care provider in addition to treatment because of the link to metabolic syndrome. High blood pressure, high blood sugar, excessive cholesterol and triglyceride levels, as well as extra belly fat, are all disorders that can raise a person's risk of heart disease, stroke, and type 2 diabetes. While research into the causes of pustular psoriasis has increased our understanding of the illness and may lead to new, more effective medications in the future, there is still a pressing need for a long-term therapeutic alternative. Thank you for watching Psoriasis on YouTube. Please hit those like and subscribe buttons and comment below. Remember to buckle your seatbelt.